Well, hey guys, were you just thinking about nitroglycerin? That's so weird, so was I. Actually, I have some stuff written on the board about it, which is kind of weird. But since we're here, why don't we go through a little bit of it and talk about nitroglycerin? Something we give a lot. Let's maybe dig into it a little bit more, just for fun. So, my name's Kevin, practice educator on Vancouver Island, and I thought it might be a good idea just to review nitroglycerin and get into some of the nuts and bolts of what it does and why we give it and maybe why we shouldn't. So let's go for it. First thing we're going to do is just talk about nitroglycerin and who we give it to. EMRs and PCPs can give nitroglycerin for patients with chest pain suggestive of acute coronary syndrome. So any chest discomfort, it doesn't have to be described specifically as pain, chest pressure, anything that is sort of a discomfort to patients that we think is the result of acute coronary syndrome, which could be anything like angina, or perhaps a myocardial infarction, either a non-STEMI or a STEMI as we call them, ST elevation MIs or non-ST elevation MIs. It doesn't really matter specifically what's going on, but for any pain suggestive of coronary ischemia, we can give nitroglycerin. So what can EMRs and PCPs give? Well, if the patient already has a prescription and we sort of meet the parameters and rule out some contraindications, which we'll talk about in a bit, you can go ahead and give up to 3 sprays of nitro. If the chest pain is persisting and we want to give more, then we're going to consult EPOS about that or Clinical. We can also go ahead and give it to people who don't have a prescription, but there is a requirement that we consult with Clinical prior to going ahead and just giving that to people who don't have a prescription. So let's say the decision is made that we are going to give nitro. What does it do and why are we giving it? So let's talk about that for a sec. We decide to go ahead and give some nitro to somebody. It goes into the body. And the main effect of nitroglycerin, what it's going to do is be converted into something called nitric oxide, which is NO. It's different than nitrous oxide, which is N-TOX, which is actually N2O. But this is nitric oxide, and it's something that the body makes anyways. It has a role in vasodilation, which we're going to see in a minute. So nitroglycerin very quickly gets turned into nitric oxide. And what does that do in the endothelium? Well, it actually works on an enzyme called GC, or guanylyl cyclase, if you really want to know. But GC has an important role in that it converts GTP into cyclic GMP. You don't really need to know what those stand for. It's certainly not something worth remembering on a call. But this conversion of GTP into cyclic GMP is just a chemical reaction, an enzymatic reaction in the endothelium. And the result of this is that cyclic GMP actually acts to decrease the amount of calcium in the muscles around the blood vessels. It also actually decreases just the general muscle goodness of it. It actually acts on the myosin fibers. There's actin and myosin in muscles. It actually acts on the myosin fibers to make them less likely to contract. So what we end up with is not only a reduction in calcium in the muscle, but also muscles that just aren't as interested in contracting even if there was more calcium. So those two mechanisms work together to actually cause the muscle to just chill. So all the muscles around just vasodilate. So wherever this is acting, we start to see relaxation of the muscle around either the veins or the arteries. And nitro is an interesting drug because it actually works primarily more at lower doses, or as you're getting into it, on the veins itself. And then with higher doses or repeated dosing, it actually also has an effect on the arteries and the coronary arteries. So that's the essence of what happens here. This is, again, the endothelium. This is a blood vessel. You can tell because there's happy little red blood cells floating around in here. So when all of this occurs, we give the nitro and it goes through this process of converting GTP into cyclic GMP, lowers the calcium, chills out the muscles in the myosin, and it leads to vasodilation. We're going to talk a little bit about why that actually addresses somebody who is having some chest pain. So, yeah, that's it. Why don't we go and talk about the actual physical effects of that? Then we're going to talk a bit about the contraindications in the use of it. So when we talk about the actual effect of nitroglycerin, we've talked about how it actually has that effect through nitric oxide in the body. What does that actually matter? Well, here you can see an extremely detailed picture of an actual person. How do we know it's a person? Because I put a belly button right there, so I think it really makes it clear. This is a very, this might be a bit complicated, but this is a diagram of the heart. Here's our right atrium, our right ventricle, our left atrium, and our left ventricle. And what we see, of course, is we see that we have the veins feeding into the right side of the heart, and then, obviously blood goes through the lungs and comes out of the left side of the heart into the arterial system. So what is nitro doing? Well, nitro is doing a couple of things. The first thing it's going to do with this vasodilation that it causes is to act on the veins predominantly right away. And what you're going to see is you're going to see the veins all over the body, like in the legs, liver, tissues all over the place. You're going to see these veins dilate as those blood vessels relax. And as those veins dilate out, what you're going to see is you're going to see a drop in the actual amount of blood returning to the heart right here and returning into the right atrium and the right ventricle. I wrote the cardiac output equation up here. Most people might be familiar with that by now. But one important aspect of the stroke volume part of this equation is preload. And I'm just going to hit a P here for preload because I'm too lazy to write the whole thing. But when we increase the size of the veins all through the body and decrease the amount of blood returning to the heart, we're actually causing a decrease in the preload. And if we decrease the preload, what happens is we actually decrease the amount of effort that the heart has to expend to eject that blood that's sitting in the ventricle out. As a result of that, because the heart's working less hard, it needs less oxygen, and therefore, even in somebody who has chest pain from an ischemic cause where the heart maybe isn't getting enough oxygen, this can help to decrease the pain because the heart just doesn't have to work as hard. The downside is, eventually, this can actually lead to a little bit of a decrease in cardiac output because, of course, this is an equation where heart rate plays a factor, but then so too does the stroke volume. And we just talked about the preload. Now, as the actual drug kicks in, as we give more of it, it's sort of what they call a dose-dependent effect. You start to see more and more effect on the arterial side as well. Not just the arterial side, but also you start to see an effect on the actual coronary arteries themselves going through here. And nitro starts to cause the same vasodilation using the same mechanism with nitric oxide, cyclic GMP, and then decreasing the calcium and telling the muscles to chill out. And you get the same effect here where arteries or little arterioles in the body, generally slightly bigger ones, not tiny, tiny ones, start to dilate as well. So when things dilate on this end, that means that the heart has an easier time pushing blood into the arterial system. So when it has an easier time doing that, what we actually see is a decrease in what's called the afterload. And the afterload is just what the heart has to push against to make blood go out to the tissues. So if we decrease the afterload, the same thing happens. The heart doesn't have to work as hard, it doesn't need as much oxygen, and therefore some of the pain can go away because whatever oxygen it is getting all of a sudden becomes enough for the heart in that particular moment in time. The last effect related to the arteries is that it actually causes dilation of some of the coronary arteries as well. So it causes dilation where those coronary arteries can actually open up a little bit to improve blood flow to the myocardium itself. So it improves that blood flow, and it improves the blood flow to vessels around. If you have an area where you have a big giant block in one of these coronary vessels, there's still a bunch of other little vessels all around it trying to feed that area. And those can dilate too to help get oxygen around the blockage to that area of the heart. So anytime I can get more oxygen to a damaged or threatened area of the heart, I might have an effect on the pain and actually decrease it a little bit. So that's what we're looking at in terms of how nitroglycerin works. Now, what are some of the downsides? Well, if I'm going to decrease my preload and decrease my afterload, I can start to change my cardiac output. Depending on what the heart rate does in response to that, I can either actually increase my overall cardiac output or decrease my overall cardiac output. The other big thing to think about is on the arterial side, if I start to open this all up, and that's not an aneurysm, I'm just representing the fact that their arteries are open generally throughout the body, is that you're actually you can drop their blood pressure because you're dropping the resistance that heart has to work against, which can be a good thing up to a point, but we can also drop their blood pressure so much that you don't get as much flow of blood through the body, and all of a sudden people can become dizzy and hypotensive, headaches, that kind of thing. So there are some definite downsides to giving the nitroglycerin. And I think what it's important that we do is just go over and have a quick talk about the actual contraindications, and then we'll kind of wrap all of this up. So I think it's important that we get into the contraindications. I don't know if you're anything like me, remembering lists of contraindications doesn't stick in the noggin at all. So I think we're just going to go through them and explain why they're contraindications. And that might help you think it through the next time you're faced with giving somebody nitro, especially somebody who doesn't have a prescription, where we might be a little bit more careful about administering it. Somebody who has a prescription, we're probably more likely to go ahead and give it. Regardless, we should always be thinking about what the downsides might be. So the first one is allergy. If somebody's allergic to something, don't give them something. Got it? Yeah, that one's easy. All right, don't give it to that. Sildenafil. So sildenafil is Viagra, so Viagra, Cialis, Levitra. Levitra? Sounds right. So any erectile dysfunction drug given within the last 24 to 48 hours, depending on the drug, we don't want to give those folks nitro. Now, why is that? We always know that's a contraindication, and most people probably know that it's because of hypotension. So the issue is, when we give somebody a spray of nitroglycerin, like we talked about, you can drop their blood pressure as you decrease that afterload, decrease that arterial side, and to a point, the venous side as well. But how does that work? Well, if we go back to our little picture here that we had, remember we have GTP being changed into cyclic GMP by this GC guy right here, and that's what's leading to the drop in calcium and the drop in muscle goodness and everything chilling out and venodilating. Well, these drugs here, sildenafil, Viagra, Levitra, Cialis, these are what's called phosphodiesterase inhibitors. So these work right here on the PD, phosphodiesterase. So what these do is these block phosphodiesterase. And that's important because normally what happens is this cyclic GMP that causes all of this chilling out is usually broken down by phosphodiesterase into GMP. Not the cyclic, but just the GMP. So what happens is if we block this, so we can't convert this into GMP, we're going to push more of this way. And so we end up getting an additive effect. Not only are we giving our nitro and getting this stuff to drop the calcium, decrease the muscle goodness, we're also stopping this stuff from being broken down and going away. And so it has an additive effect where all of a sudden you get this profound vasodilation and hypotension. So that's why we don't want to give those drugs within 24 to 48 hours, because it super compounds the problem and can precipitously drop somebody's blood pressure. So there we go. Don't give it. Next, anemia. Why is anemia a contraindication to giving nitro? You know, you can come up with some fancy reasons or think it through. There's a lot of other sort of chemical stuff with regards to giving people nitrates or nitrate-derived drugs that might play into it a little bit. But I think the biggest reason we don't give it to somebody in anemia is because anemia just suggests that we have less of our happy little red blood cells, right? All of a sudden we're anemic. We're anemic. We don't have as many of these. And as a result, the remaining hemoglobins or red blood cells are sad. So with anemia, we have less oxygen carrying capacity in the body. The whole point of cardiac output, where we have cardiac output, heart rate, stroke volume, is to get blood out there, get oxygen to the tissues. Well, if we don't have much oxygen in the blood, then potentially dropping the cardiac output by dropping the preload, dropping the cardiac output with the effective nitro, will even have a worse effect. So that's why somebody who's anemic, which you might not really know unless they tell you they're anemic, or you start to get into the numbers of hemoglobin and stuff like that, which isn't really as relevant, is just something to think about. If they have a history of anemia, if they're super pale, very pale or clear sclera and stuff like that, things can point to anemia. But for the most part, you're just going to rule out, any big bleeding recently, any chronic problems with anemia. That might be something to just run by the clinical group when you talk to them and discuss the benefit versus risk of giving nitroglycerin. So anemia is something to think about. A loss of blood or a low hemoglobin in their blood might be something you think about because you want to maintain that oxygen delivery. Another one, constrictive pericarditis. Things like this, the reason this is a problem is because the pericardium is just a fibrous sac around the heart, right? It's tough, actually. It's tough, it's around the heart, doesn't stretch very much. And what can happen is when we play with the preload, in terms of dropping the preload side on the venous side that we talked about, things that constrict the heart can really mess around with the interplay between cardiac output and preload. And so dropping preload in people with constrictive pericarditis or hypertrophic cardiomyopathies or anything like that can really start to impact the balance of how much preload the heart needs to maintain a good cardiac output. You would really only find out about this if they told you, if they had a history. I certainly don't expect everybody to go around asking everybody if they have constrictive pericarditis, but if that happened to come up, it's probably something worth noting and passing on to perhaps the clinical group. A right-sided MI. Should we give nitro to right-sided MI? You can Google that and there'll be a billion things you can read about it. Should you give it to somebody with a right-sided MI? The answer, of course, in medicine is always maybe. So maybe you should, maybe you shouldn't. A right-sided MI is referring mostly to the possibility that the right ventricle might be involved. And if the right ventricle is involved and we drop that preload, well, we can really have an impact on the cardiac output because all the blood obviously has to go through the right side to get to the left side. And if that right side of the heart is somehow buggered and it can't pump out for a given preload, well, you're gonna drop your cardiac output. That being said, it's not always easy to tell if the right ventricle is actually involved in somebody having an MI. Even if you're in the situation where you have a 12 lead, there are some signs that can suggest it's actually involving the right ventricle, but you don't know for sure. And that's why the guidelines are written the way they are, with a blood pressure target and a heart rate target. So we might not know if somebody's having a right-sided MI. If we do know, then of course we might want to not give nitro. But if we're not sure, we look for other signs like a precipitous drop in blood pressure. If their blood pressure is 120 and you give them a spray of nitro and their blood pressure is 60, don't give them more nitro. All right, good, right-sided MI. Hypotension and hypovolemia. That seems pretty obvious. If they have crappy preload, don't more crappy their preload. Okay, done. Systolic blood pressure less than 110. This is what we're getting into talking about. Nitro generally drops blood pressures. This is kind of a safe goal where we have a bit of wiggle room. If we drop their blood pressure too much, they'll probably recover very quickly. Nitro only lasts a few minutes in the body before it's all taken up and gone. So usually if somebody drops their blood pressure in response to a spray of nitro, lying them down and waiting is generally the way to go. Saying you have to have an IV before you give somebody a spray of nitro, I've always kind of wondered, like, what are you going to do? Give them a bolus of 500 of fluid and somebody with ischemic chest pain in response to a short-acting nitrate? That doesn't seem right, because what you're now doing is maybe putting them at risk of other problems like pulmonary edema or volume overload. So just wait if their blood pressure drops and see how it goes. Lie them down. But this is the guideline. Systolic, below 110, we're not going to give nitro. Same thing if their heart rate is above 150 or below 50. And again, that all comes back to the cardiac output equation again. So there you go. That's a little more long-winded than I wanted to be. But we've kind of covered nitro, we've covered the administration, how it works. We went and talked about sort of the general body effects, and we talked about contraindications. So stay tuned because part 2 is fascinating, but we're actually just going to do more sciencey stuff with another equation. That'll be shorter. But there you go. Let's get on to that. I'll try to leave some good references at the end for you again. And yeah, hope you're having a great day. Thanks very much. Okay, guys, here you have it. Here is the bonus science part. And this is just an equation. So if it's not your jam, totally understand. I won't even be offended. But what I really want to talk to you about here, because it helps tie in a little bit around in general, the cardiac output equation and stuff, but also some of the contraindications we talked about with nitro, is this DO2 equation. DO2 simply stands for delivery of oxygen. How much oxygen are we delivering to the tissues in general? Delivery of oxygen. This just helps us quantify it and put some numbers to it. So I'm just going to talk you through this real quick because it might help you in the future or just might be interesting to you. So delivery of oxygen. The first part of this equation is CO. Well, what's CO? I'm sure we all remember and we just talked about it. This just refers to, like we said, heart rate times stroke volume. And of course, stroke volume, you remember we talked about preload, which we talked about earlier, afterload, which we talked about as an effective nitro as well, and we didn't really talk about it, but contractility or how well the heart is actually working. So the cardiac output, heart rate times stroke volume, is kind of all embedded in here as the first part of how we deliver oxygen to the tissues. And it makes sense. This is the mechanical part of like actually just moving some blood to the tissues. But what the DO2 equation does is it kind of takes this concept just one step further. So here we have cardiac output, heart rate, and stroke volume. But when we talk about delivering oxygen to the tissues, not only do we have to talk about moving blood, we also have to talk about what's in the blood. So this part of the equation, which just seems long and annoying, so I'm going to break it down for you, just talks about how much actual oxygen is in the blood. It's one thing to move that blood, but how much oxygen is in it? So the first thing we have here is we actually have the number 1.39. And actually sometimes you'll see this will be 1.34, but 1.39 is pretty common. And what that refers to is just how much oxygen hemoglobin can hold. So how much oxygen can hemoglobin hold? And this is actually just refers to, if you're interested, how many milliliters of oxygen can we hold per gram of hemoglobin? So this is just a measurement, just a constant of how much oxygen some hemoglobin can hold on to. So that's important to know. The next thing we need to know is, well, how much actual hemoglobin is in the body? If you're anemic, remember anemia is one of the contraindications, that'll lower your hemoglobin. If we lower our hemoglobin, we're going to lower the overall amount of oxygen being carried. Even if this is all good, we're going to lower our delivery of oxygen. So the concentration of hemoglobin or anemia can be a potential problem. This part right here simply talks about the SaO2, which just stands for the saturation or the arterial saturation of oxygen. And SaO2, which you get from actually like poking the artery and doing a blood gas, correlates very well to an SpO2 or an oxygen sat. Kind of makes sense, right? It's one thing if we can carry oxygen, but the question is, are we? What's the saturation? Are those hemoglobins saturated or not? If they're nicely saturated, we're doing a good job of delivering oxygen. If we have low sats, probably no surprise, we're doing a poor job of delivering oxygen. And the last part right here just refers to how much oxygen is just directly dissolved in the blood, not being carried by hemoglobin around just royally, but being actually dissolved in the blood. See, it's 0.003 times the pressure of oxygen, and that's come up before, but the end result is this doesn't account for too much oxygen carrying. So what we're really left with to deliver oxygen to the tissues, we need to look at our cardiac output overall. Are we actually moving blood there? And how much oxygen is in it, which is basically driven by how much hemoglobin do we have and how well is it saturated. So that kind of helps to explain that, put the anemia contraindication into a bit more perspective, and let's be honest, it's just fun to know. So there you go. Put a couple of references at the end. Hope you have a great day. Talk to you soon.